Okay, well, thank you. Thank you, Sasha, for the introduction. This is the last day. I see still some people here. It's amazing. So I want to first congratulate the whole team of Hidaki and Mitsui and Shihai for this wonderful time together, scientifically and socially. It's another great party. As one of the organizers last year, I can feel your relief and sadness. The party is over, but we all look forward to next year in Chile. It's going to be very exciting. So the topic I was given by Shihai is cutting-edge technologies in cardiovascular imaging. We have seen so much in the last 3 years, I don't know what is cutting edge anymore. So I changed the topic briefly to just have an incomplete summary of what's going on from my point of view, what is something new about technology development in the last few years in cardiovascular imaging. Again, I'm going to miss a lot of the great stuff, and I collect a lot of slides, but as Hidaki was saying that we have a very tight schedule, so I'm going to miss a lot of the slides and go quickly. So first, I want to talk about cardiac imaging. I think as you all agree that the trend is quantitative imaging with parametric mapping and also with a single scan to cover multi-dimensions of motion and different mapping and multi-parameters and multi-contrast. So this is kind of the trend, and I think Matthias had talked about this yesterday, and it's more efficient and can simplify the workflow, and also potentially we can use multi-parametric quantification to perhaps without contrast to do LGE without contrast. So that's the possibility. So I want to first start with this technique, multitasking. Everybody has know this already. This is developed by Anthony Cristolo in our group for a few years ago, and has many capabilities of resolve motion and time dimensions to allow completely ECG-less and free breathing cardiac imaging with the T1, T2 mapping. So this figure is in that paper we published in Nature BME that shows the initial feasibility of using parametric mapping T1, T2 to predict LGE. So I think this has not been really discussed a lot, but I think this is something I think we should definitely think about to, with maybe more parameters, T1, T2, T star, and T1 rho, and many other parameters we can integrate, like CEST, for example. I'll talk a little bit later. But with all those parametric mapping, could we finally do without contrast? So that's something that we should consider. So we first extended the capability of even more parameters. In this paper published last year, we were able to do T1, T2, T star, and fat fraction mapping in one scan with this multitasking framework. And this is further work in our group by Randy Yang, faculty in Cedars-Sinai, that he extended this to using this framework to do QSM. So the advantage of this is that we can map out the B0 map so that we can correct for the field homogeneity to really collect a very good quality QSM phase information in the heart. So you can see here this example of if you do, the goal is to do iron depletion. This is a very important biomarker for predicting adverse events for heart failure patients with MI patients. So this traditionally used R2 star is a lot of artifacts, as you can imagine, but with QSM, and you can definitely help to remove those artifacts by mapping the B0, and if you do standard QSM, you see a lot of artifacts here, but if you remove this B0 effect and do this multitasking framework-based QSM, you can see the quality is much, much better to allow this accurate QSM mapping. So another direction, as you know, we have been doing bone imaging in the heart for many years, and this is again Randy's work to use this multitasking T2 mapping, dynamic T2 mapping, to really give you some kind of functional MRI-based type of imaging in the heart, in the brain. So you can repeatedly mapping out the T2 and give you the confidence of the bone imaging in the heart, which is very difficult in the heart. So further on, he did the T2 and PC mapping using, again, multitasking framework to quantify the oxygen consumption in the heart by looking at the T2 to give you oxygenation level measurement, and also the phase contrast imaging to give you the blood volume measurements, and you put together to calculate the oxygen consumption, and you can see some good qualities of the phase map in the heart and the T2 map together. So Matthias had talked about this already. I mean, he's doing something analogous to this, and it's free running 5D imaging, and he did more in the coronary imaging, superb quality of coronary imaging, 4D, 5D, and also the flow. So this is, again, something that they are very good at it, and I think he showed us already. I'm not going to talk more about this. So talking about coronary imaging, this is something that ferumoxytol, as you know, has been used a lot for whole body MRA, and this result was given to me by Dr. Yuehong Liu and Qi Yang from the Capital Medical University in China, and they have used this for coronary imaging, and you see a very good quality of the coronary images with this ferumoxytol enhanced imaging. And just briefly, we have been also doing CES imaging. In the heart, again, it's very challenging because of the homogeneity and all the motion and stuff, but we've been working with this Dr. Yining Wang from the Union Hospital in China, and showed that this CES imaging can detect the area of LGE without contrast, and this is a group of patients with the AL disease, and shows a good correlation between the assessed signal and LGE. And something new in the hardware, this is a new Siemens scanner. It's called SIMA X. It's already installed and FDA approved. So this gives you a 200 millitesla per meter gradient, which is going to be really great for diffusion-weighted imaging in the heart, in particular in the heart. So this is the work by Chris Wen in Cleveland Clinic. This is a really fresh out wire, and it's just the last few weeks. He was able to show that in diffusion-weighted imaging, you need to have second-order compensation, flow compensation, and by this high gradient, you can reduce the TE from the 120 milliseconds to about 60, so reduce the TE by half, and you can see the quality is much better, and the SNR is much better also. So non-contrast, we see a lot of non-contrast imaging. Many different groups are working on different directions. So we received a lot of slides, but I've seen so much discussion already, so I'm not going to cover any of this. Plaque imaging is another direction that many groups are working on, and the direction is also to focus on single scan with multiple contrast and quantitative imaging, and also the possibility of non-contrast. So this is a Q-match based on the multitasking framework. We can do T1, T2 mapping and multiple different contrasts in one scan. This is developed by Ibn Xie in our group. And we can show that you can look at the lipid core with T1, T2 mapping, black blood and red blood, and all these different contrasts, 7, 8 different type of contrast, and then you can look at the mapping of hemorrhage and lipid, and very clearly indicated, correlated with pathology. Again, the advantage of this is that when you have multiple parameters, you can do a quantitative clustering analysis to really give you a better characterization and separation of different types of tissues. So this has been undergoing clinical trial. One of the protocols is this. There are other protocols as well, but one of the protocols is this, to use multitasking Q-match to look at the carotid plaque imaging in collaboration with Siemens, and 5 centers involved here. And this is another example I want to show. This is given to me by Dr. Huijun Chen in Tsinghua. He's also included T1, T2, and T2 star mapping in the same scan. Coronary imaging is another direction, plaque imaging. We discussed on the first day of why we do this and if the CT is so good. But my point is that I think we can do this very well. I mean, the coronary and plaque imaging. And we can use this as an add-on to a comprehensive CMR exam. And to me, I think I actually do this myself every year just to monitor my coronary. I have full confidence in it. I'm obviously a motivated collaborator. I mean, a volunteer. I can do a good job of staying still, but the quality is superb, and I think I feel good about it when I don't see anything. So I've been working closely with Dr. Matsumoto in Japan with multi-center studies, and this has been published in Radiology, and time is running out. I'm going very quickly, but I think it shows some good value of this technique to look at predict, for example, the PCI injury after PCI, the myocardial injury. So this is very good to do that. And then we have some collaboration with South Korea with Dr. Chang, and look at the correlation with FFR. And you can see that stenosis does not give you the full story. And I think this plaque imaging gives you much more correlation with FFR. So, and some more work, and I don't want to go too much. And this is the work, I mean, still, René Partner is not here, but I think he has this boost technique. I think Siemens, Christian has presented this in the Siemens presentation. This is give you both black and blood and bright blood in the heart, and look at the coronaries and look at the plaque in one scan. So next, I want very briefly talk about AI. I mean, we have a lot of AI presentation in this meeting, and it can give you faster acquisition, faster reconstruction. Also, again, helps to do without contrast. This is a work by Dr. Gao and from UCLA and Dr. Paul Finn, and they're using this spatial temporal network to reduce the scan time, and by doing this deep learning-based acquisition, you can accelerate the CINI by a factor of 14. So this is really amazing work, and there are many others have been doing the same thing. Anthony has been doing this for the multitasking deep learning-based recon to reduce the recon time from many minutes to less than a second. So this is something that really needed in order for this multitasking and others to be clinically useful. And this is a recent publication in Circulation from Oxford, and showing that by using T1 mapping and CINI, you can predict the LGE, just 2 information alone. And this again, look at the scar analysis and has a very good correlation. Low field has a lot of discussion already, and this is Lang Samanati's work in Cleveland Clinic, in the Ohio State, and showing this LGE imaging. You can do perfusion. I think it's quite amazing that given the challenges of low SNR at low field, they can do such a good job. It's really, really exciting. And again, René Partner had done this, the same thing with this boost imaging technique at 0.5T. And again, getting some really great results, even some coronaries. I mean, it's really amazing, and you can do a good job of fat suppression and get some really good quality of coronary MRA. This is very exciting. And mapping, T1T2 mapping also. High field is, we have not seen a lot in this meeting, but I was looking for this paper You can look at the intracranial plaque imaging. You can see much better resolution and definition of the lumen and plaque. But again, high field is not readily available, so it's something that we should keep an eye on. But last, I want to just mention briefly that we have a really strong, not computation, but alternative imaging modality of photon counting CT, and you're getting some really great high resolution, 0.2 millimeter resolution. You can see the calcium much better defined without the blooming effects. And also they can do LGE. I mean, the quality is not good yet as compared to CMR, but is there. I mean, you can see it. So again, this is something we should keep an eye on. So in summary, I think I think you should agree that quantitative imaging is the way to go in the future. In a single scan with multiple dimensional imaging, motion resolved, the multi-parametric mapping and contrast, again, also the trend. And if you can do without contrast, would be ideal. And there are a lot of techniques being developed, ASL-based MRA and 4D flow and many others. AI is the way to go, and many things can benefit from AI. And low field is very exciting, but there are many challenges. I think we discussed this on the first day. We have to show that we can be reproducible and we can standardize the protocols, and we need multi-center studies. So that's my talk, and thank you very much for your attention.
Thanks very much, Debiao. There's one quick question.
Yeah, Debiao, I'm blown away by you and all the other people that have really pushed cardiac, but I want to throw out a challenge as somebody who's doing body imaging more, which should be simpler, but liver and pancreatic imaging, abdominal imaging still suffers from a lot of motion artifacts, a lot of failures, and I think somebody needs to think about some of these amazing techniques in cardiac and apply them to what should be a simpler body part. So I'll just throw that gauntlet out to the, to the society.
Thank you so much for that. And actually, that's what something we're already doing, and I didn't show that, but we have been, actually most of our work in the last few years has been in the body, in the pancreas. We can talk afterwards, but it's definitely much better than heart in terms of better motion control, because you don't have that additional cardiac motion. So definitely, I agree completely. Yeah, thank you.
Thanks again, Debiao.